My name is Danny Siegel. I'm one of the chief residents. It's my honor and it's my privilege to introduce our grand round speaker for the day. Dr. Jeffrey Weiss is a professor and the chair of the Department of Urology at SUNY Downstate College of Medicine. He received his bachelor's degree in biochemistry from Cornell University and graduated AOA from the University of Pittsburgh School of Medicine. He completed his urology residency at UPenn. Thereafter, he did a fellowship in neurourology and urodynamics at the Cornell Medical Center under the tutelage of Dr. Blavis. He's the primary author of over 400 peer-reviewed articles, abstracts, and book chapters, as well as co-author of 5 urologic textbooks. He's a member of the AUA, the International Continence Society, the Society for Urodynamics and Female Urology, and the International Consultation of Incontinence and Research Society. He's currently engaged in research regarding the cause and treatment of nocturia. He has received the Editorial Review of the Year honors from the Journal of Urology for urodynamics and female urology on 3 separate occasions. In addition to all of these amazing accolades, Dr. Weiss has many other talents. For example, he can surely tell you the names of the mascots for any high school sports team on Long Island. Additionally, he's the chair of the department, which puts out one of, if not the most medical students into urology on a yearly basis. Having been a student under Dr. Weiss, who is interested in urology, I can say that he's an excellent mentor who cares deeply about his patients, his faculty, his residents, and of course, his students. He's a huge reason as to why Downstate is so successful in urology and why their students are spread across the country. He's also a huge reason as to why I chose urology and ended up here at Yale. In fact, we at Yale have 3 current residents, 1 current faculty, and 1 retired chair, although before his time, who all went to Downstate for medical school. Without further ado, I'm proud to introduce Dr. Weiss to our grand rounds today to give us what is sure to be a great presentation about a topic which we all have, we're sure will soon encounter. That's nocturia. Take it away, Dr. Weiss.
Thanks so much for that wonderful and undeserved introduction, Danny. I could wax poetic about you and your compatriots who have gone throughout the country in urology, but not much time. We've got a lot to cover here on my favorite topic. So I will share my screen and it'll let me know how we're doing here. Let's see. Does that look pretty good on your screen? Awesome. All right, great. So we're going to talk a little bit about nocturia. This is something that everybody sees. It's a very difficult thing to treat because there's so many ways to treat it and so many contributing factors. I would like to think that we've made some progress in basic science and clinical science. So just a little bit of an outline as to what we'll talk about. We'll define nocturia, talk about consequences, most importantly, the diary analysis of nocturia, describing the different categories of nocturia, such as nocturnal urine overproduction or nocturnal polyuria, low bladder capacity, and the global polyuria. There's some of the evidence for cause-specific treatment, basic science inspirations, and future considerations. So what's nocturia? It's voiding during sleep, even just one time. It can be divided into medical or renal, that's upper tract causes, and that's the nocturnal polyuria or polyuria. I call that the waterfall. And then there's the lower tract dysfunction due to low capacity that can be due to a variety of reasons. That's what we urologists think we're very good at. The problem is it is very difficult to increase bladder capacity and make the reservoir bigger. So it turns out that diminishing the waterfall is probably, at this point in time, the more effective approach to most patients with nocturia. So who has nocturia? Well, men and women have nocturia. And in the early going, it's the women who have more than the men, and it equals out by the 6th decade. And then thereafter, the men kind of surpass women in prevalence. And that's this slide is for nocturia at least once. And the same sorts of data will be shown for all the other varieties of more severe nocturia. Now, are we going to have everybody in our office with a little bit of nocturia treated? No, not at all. In the Finnish National Nocturia and Overactive Bladder study, authored by Dr. Kari Tikkanen from Helsinki, he did a mailing study and found that it's probably about 5% of the patients with nocturia who have at least moderate bother, those will be the candidates for treatment. So 5% sounds like a small number, but it's a small number of almost everybody. So it's actually a big number of patients. We just got finished with a monumental study on the epidemiology of nocturnal polyuria. There's a lot to this study, summarized in this EAU article, a European Urology article. I just want to highlight one thing from this that I think is really important, and that's the concept of idiopathic nocturnal polyuria. This is where patients who are perfectly healthy without risk factors such as heart failure or even peripheral edema or even sleep apnea, but they still have nocturnal polyuria. And depending upon the definition and whether you're talking about men or women, the incidence is anywhere from 1.5 to 10%. So up to 10% have this condition, which was a term coined in the 90s by Dr. Ragnar Asplund, kind of the father of Nocturia from Sweden. He called it the nocturnal polyuria syndrome and thought it was actually a deficiency syndrome where antidiuretic hormone did not increase physiologically during the hours of sleep. So up to 10% of patients have this syndrome, and I believe strongly that those are the patients who will primarily be candidates for desmopressin, and I'm looking at desmopressin as a replacement therapy in those patients. In order to know who they are, you have to study them, and we'll talk about how to study these patients. Key insights also, it's possible to have nocturia with nocturnal polyuria or without. So you don't have to have that waterfall to have nocturia. And those are clearly the patients with low bladder capacity. And you can see here that in the idiopathic category, between about 2.5 per night, nocturia, men and women, and maybe a little less for the ones who do not have nocturnal polyuria. But what you can see is that both the nocturnal diuresis rate in the idiopathic nocturnal polyuria and the 24-hour outputs are far greater in those patients than the ones who did not have nocturnal polyuria. So these are the patients where fluid volume makes the big difference. And in the patients with no nocturnal polyuria, clearly you want to do something about bladder capacity if you can. But the key is to match the output with the reservoir with bladder capacity. So here's the causes of nocturia. It's a blessing and a curse. It's great medicine, and unfortunately, it takes a long time to evaluate these patients, which is why so many doctors just don't want to deal with it, because everybody knows how much time we all have to see individual patients, and nocturia evaluations really are demanding on our time. So the factors that we have to look at are manifold: sleep problems, hormonal problems, renal disease, lower tract, intake, so that's behavioral, and cardiovascular implications. There's a lot of good medicine that we have an opportunity to practice here. So what are the consequences of nocturia? Well, basically it's mediated by sleep deprivation. And what we know here, and this is really interesting data from NHANES, is that patients who have significant nocturia times 2 or more have far worse survival over the course of 10 or more years in both men and women. This is a big study, and then it raises the question, does nocturia kill? Well, it doesn't actually say that, but what it does say that either nocturia itself is morbid or the factors that cause nocturia are morbid. One way or another, I think it makes it worthwhile to investigate and treat nocturia when it's a particularly a chief complaint. The only study prior to the epidemiology of nocturnal polyuria, the EPNP study, was ever done was in Holland. And this was Dr. Ruud Bosch, who did a wonderful diary study in the 1990s. And he followed over 1,000 men for 6 years and got diaries at year 0, 2, 4, and 6.5, and then followed them for a mean of 13 years and found that in the univariate analysis, there was an association in his patients, which were all men, by the way, between 50 and 78. There was an association with mortality, but in the multivariate analysis, where all the risk factors for mortality were split out, nocturia was not associated with mortality. But note that in that particular population, these were not nocturia patients primarily. Like the younger men only had nocturia ×1, and the older men only 1.5. So I wouldn't draw too many conclusions on the mortality issue from the Crimpin study. There was a wonderful systematic review that was senior authored by Carrie Tikkanen, who I think is one of the great Euro-epidemiologists in the world. And they found, through a review of the literature, a consistent evidence of increased mortality for men and women equal to about 28% excess risk per year. So considerable. Evaluation, history, physical, urinalysis, make sure they're not in retention, and do avoiding diary. They don't need a cystoscopy, they don't need urodynamic studies. And I'll explain to you how to evaluate avoiding diary. The first morning void, the volume is included in the nocturnal urine volume, particularly when voiding occurs within 30 minutes of arising. But that first morning void is a daytime void itself, not nocturnal. So the actual number of nightly voids would not include that first void, but the volume would go into the tally of the nocturnal urine volume. If you divide that nocturnal urine volume by 24-hour volume, you get a number, and it had to have a name. The ratio is called the Nocturnal Polyuria Index, and almost arbitrarily, more than a third is considered nocturnal polyuria. This is probably true. It turns out that everybody, except for everybody in this room, sleeps about 8 hours. So that's about a third. Now, of course, this number assumes that diuresis rates are level during day and night, and that is not true. However, we know that elderly people do not excrete normally more than about 34% of their global 24-hour urine output at night. So 33%, while it was chosen randomly almost or arbitrarily, turns out to be a pretty good number. And it is the number that most people rely on worldwide. The Nocturia index compares nocturnal urine volume with bladder capacity. So the number greater than 1, the ratio over 1, means that nocturia occurs because functional bladder capacity is exceeded. Now, the nocturnal bladder capacity index is an indication of the degree to which patients void at night at volumes less than their own capacity. So the higher the NBCI, the more nocturia occurs at voided volumes less than their own capacity. So the way this works, nocturnal bladder capacity equals actual minus predicted number of nightly voids. The predicted number of nightly voids is the Nocturia index -1. That was an empirically derived mathematical equation. I sat on the train going to New York during my fellowship for a year and just kind of thought of all situations and realized that this was probably a true statement. And so the way it works is, for example, someone with nocturia ×7 and a nocturnal urine output of 750, but can only hold a maximum of 250, you would think, not knowing anything about the math, that if they voided a capacity at 250 every time, they'd have to go 250 the first time, 250 the second time, and then when they get up in the morning, they have that third 250 to make the 750 that they were destined to void. So the Nocturia index here is 750 over 250, which is 3, subtract 1, and we got the number 2, which was the predicted number of nightly voids based on capacity. But I just told you the patient got up 7 times. So that means that the patient got up a lot more than the twice, which means that they voided at volumes far less and consistently less than their own capacity. So what's a high number? Anything greater than 2. So the higher this NBCI, the more they are voiding at night due to volumes less than their own capacity. So even if they don't have a great capacity, if we could get patients to void at night at their capacity in some way, that would certainly resolve a good deal of nocturia with no drugs. So this is just a summary of what I just said in terms of how to figure out the diary. And then once you get these values, you have categories, and then you have gamuts of medical conditions. So if you know that the patient has, let's say, a nocturnal polyuria index of 50, they have nocturnal polyuria. So what causes that? Well, you kind of look at them to see whether they have heart failure, do they have diabetes, and we will diagnose glycosuria and diabetes with new onset based on the chief complaint of nocturia. Sleep apnea, it's a big one, particularly prominent and a good target for therapy in younger patients who don't have a lot of competing causes for nocturnal polyuria. I always look at the legs, peripheral edema. If they have peripheral edema when they lie down, that fluid is going back into circulation. It's going to be peed out at night. Behavior, excessive nighttime fluid intake. I just described to you the nocturnal polyuria syndrome. And then there's one more, non-dipping. Blood pressure is supposed to go down at night. That's a kind of a mechanism for the cardiovascular system to preserve itself and offload some of the work of the heart at night. It is a kind of an auto-regulation independent of the RAS system. And if there's no dipping of the blood pressure, that can cause a pressure natriuresis and nocturnal polyuria. A lot more research needs to be done on how to manage that. The decreased capacities day and night, I can't say that we're very good at distinguishing low night versus global low capacity. But as urologists, we know all of these factors that cause low capacity: prostatic obstruction, detrusor overactivity, cancer, pelvic floor dysfunction, drugs, stones in the bladder, stones in the ureter. We think we're good at these things, but not much that we do actually increases capacity. That's the problem. Polyuria, one of my favorite topics, because internists talk about it all the time and almost never diagnose it because they don't do diaries. So 24-hour urine output greater than, let's say, 2.5 liters, or more specifically 40 milliliters per kilogram, will lead to a differential diagnosis of either untreated diabetes with glycosuria, diabetes insipidus, which can be central or nephrogenic, or if they have neither form of diabetes, we call it primary polydipsia, which can be dipsogenic, which is due to a structural abnormality in the brain causing increased thirst, or psychogenic / behavioral, and that's by far the most common cause of polyuria. But in any case, classification of nocturia using the diary unlocks up to 19 significant underlying medical conditions contributing to its genesis. So let's drill down on some of these classes of nocturia, talking first about nocturnal polyuria, the waterfall. So the most common description is that nocturnal polyuria index in excess of 33%, and indeed that's the main ICS definition. But another definition, which I think is more stringent, is a nocturnal polyuria, is a nocturnal diuresis rate in excess of 90 ml per hour, which turned out to be 2 standard deviations above the mean in the Crimpin study, and is also derived by receiver operating characteristic analysis done by these outstanding statisticians in Rotterdam from Erasmus University, headed by Ruud Bosch. So the question is, well, which is the criterion to use? Is it the NUP 90 ml per hour, or NPI 33? The advantage of the NUP 90 definition is that you can make the diagnosis with just a nocturnal only diary. But the point here is that when patients don't have much nocturia, you're going to diagnose nocturnal polyuria much more often with the NPI 33 definition than with the NUP 90. But the more severe the nocturia, when you get up to these nocturnal voids of 6 or 7, you can see that there's almost 100% concordance. And so they actually do measure about the same thing. I love the idea of following these patients with nocturnal only diaries, and that's where you'd have to use the nocturnal urine production rate in milliliters per hour. Now this slide looks a lot like the prior slide, except that it only talks about nocturnal polyuria. Look how many factors go into the evaluation of polyuria. Renal factors, tubular reabsorption concentration, GFR, hemodynamic factors, particularly blood pressure and central volume, the hormonal, particularly the RAS system, plus that all-important hormone secreted by the heart to protect itself against having too much stuff in it, atrial natriuretic peptide, and that interacts with antidiuretic hormone. And then there's clock genes. Did you know that almost all cells in the body actually have their own circadian rhythms? And it's just fascinating to learn a little bit about these clock genes. When you're in urology clinics, we're not going to do much with clock genes, but it's nice to know that they're there and they're doing something. Now, I had an opportunity to evaluate the baseline data of a large pharmacological study. The Pfizer company was kind enough many years ago to provide this data along with the statistician to divide men and women into tertiles of age, less than 50, 50 to 70, and greater than 70. And this was amazing because it was an OAB study. The young people had a lot of nocturia, and it's important to have a lot of nocturia when you really want to get to etiologies and also treatment outcomes. So what we learned is something that was just really eye-opening, is that as patients age, the factors that have nocturnal urine volume in the numerator, like the Nocturia index and the Nocturnal Polyuria index, that gets higher with aging groups, both men and women. So nocturnal polyuria becomes more important as an etiology of nocturia with aging, whereas the younger people had the higher NBCI, which means they were not voiding at night at their capacity as much as the older people were. So that's a target in younger people, is a nocturnal bladder capacity. If only we could figure out how to manipulate that well. So I just want to talk a little bit about the mechanism of urine production and concentration. So when arginine vasopressin is low, collecting duct is impermeable to water, and literally you would just shrivel up and become a prune if it weren't for this mechanism to reabsorb water. So what happens here? The collecting duct normally, again, impervious to water. So what happens when you need water to go back into the circulation? That would be caused by low blood pressure or high serum osmolality, or for example, high serum sodium. And you know, osmolality depends on a combination of evaluation of sodium and glucose levels. So what happens there is that you have these receptors, the V2 receptor in the basolateral membrane between the collecting duct cell and the vasa recti. Arginine vasopressin binds to that receptor and causes a second messenger reaction, which causes aquaporin 2 to cycle in these little vesicles and then intercalate themselves into the wall of the collecting duct at the level of the apical membrane. And that now allows water to flow back in to the collecting duct cell and back into the circulation. This story of aquaporins was pretty important and was the subject of the 2003 Nobel Prize by Agre and McKinnon. So factors causing diuresis via inhibition of antidiuretic hormone inhibiting water reabsorption are manifold, and particularly lithium. When you see patients on lithium, they diurese like crazy. They drink a lot in order to maintain homeostasis, and their outputs are going to be 4 or 5 liters. So whenever you see one of these diaries where they're putting out 5 liters, find out if they're on lithium. And there's not much you can do about that because they really need to be on lithium. But also prostaglandin here, you can see that prostaglandin inhibitors effectively act as antidiuretics, like antidiuretic hormone. And so that could be a treatment for nocturia. The problem is that they have probably a bit too much side effects to use every night. Okay, so now let's go to low capacity. We think we're all experts because we're urologists in this matter. Obstruction, overactivity, neurogenic bladder, various causes of cystitis, radiation cystitis, interstitial, bacterial, most commonly, uncommonly tuberculous, cancer of the bladder, prostate, urethra. You don't want to miss any of these. So definitely do the AMH workup if you have 3 or more red cells per high power field. We obviously are all plagued by doing tons of those kinds of workups. But nocturia itself is not an indication for cystoscopy, unless you really are desperate to look at potential causes for low capacity, even when they don't have microhematuria. So this factor, this detrusor overactivity at night, nocturnal detrusor overactivity, we postulated its presence in the 1990s, but really never identified it until Dr. Andy Crystal, who at that time was working at Duke as the head of the sleep lab, did this study and found that nocturnal detrusor overactivity does not normally occur. It is not due to a sleep disturbance and is not linked to nocturnal polyuria. And so what he found was fascinating. when you did concurrent polysomnograms and urodynamic studies at night, one found that when a patient had a bladder contraction, and this would be an involuntary contraction, they're OAB patients, their polysomnogram goes from flat to active. So basically an involuntary contraction wakes the patient up. So that to me is proof of the existence of nocturnal detrusor overactivity and that it actually does cause awakening. The problem here is that this study has never been reproduced. Why? Because it was paid for with drug company money, and nobody has ever thought to, let's say, put in a grant to confirm this. But I do believe that it exists and also is a target for treatment. So looking at the determinants of all of these diary-derived parameters, determinants of nocturia severity, at least in men, where we had databases in men in our VA in Brooklyn, New York, and also the Crimpin study was the community dwelling older men. And we actually compared our data. And it was amazing how similar the data was between the Dutch population and the population in New York City. And the key here is that by far, the factor which most highly correlated with nocturia severity was the Nocturia index, which makes all kinds of sense because that's the nocturnal urine volume divided by maximum voided volume. So there is the mismatch between output and capacity. And so those are both of the key parameters for treatment. We've done a lot of urodynamic studies in these patients with nocturia, and the earlier analysis, which was presented at the AUA in 2014, had a pretty clear-cut relationship between compliance of the bladder and nocturia severity. No matter what cutoff of compliance we use, 20, 40, or 60 milliliters per centimeter of water, we found that the patients who had stiff bladders had worse nocturia. Well, I really wanted to write this up and submit it finally as a manuscript. So I had our current student, Noah Panich, take a look at this. And he did an amazing multivariable study and found that it's really only the patients with bladder compliance less than 60 milliliter per centimeters of water appearing to be only a minor contributing factor to nocturia severity, because compliance is overshadowed by far by other factors such as bladder capacity, nocturnal polyuria, and global polyuria. So yes, compliance, low compliance with a cut point of 60 probably makes a difference, but is still minor in comparison to the more important variables of capacity and nocturnal and global polyuria. Well, nocturnal nocturia severity also is affected by bladder capacity, and this is a very nice example of teasing out data from the Crimpin study. The message here being low capacity is responsible for the higher degree of severe nocturia, that is nocturia times 3. So bladder capacity, major contributor to nocturia. Bladder compliance seems to be a minor contributor, which is a good thing because we're not very good at treating low bladder compliance. Okay, so I just want to talk a little bit about some advances in basic science. And these are slides derived from adjunct professor from downstate, Lori Berter, who is the head of the eponymous laboratory at the University of Pittsburgh. So given that Desopressin is excreted mainly in the urine unchanged, it's reasonable to predict that the urothelium may be a drug target. So it turns out that the urothelium is not just a membrane that's kind of a covering for all the important stuff underneath, but actually has a great number of receptors and transporters and channels, such as aquaporins, ENaC channels, urea transporters, osmose sensors, and provide potential for water and urea transport across the urothelium and for modifying urine composition, although probably that should be considered relatively minor in comparison to what the kidney does. In any case, the question that was asked by Dr. Berter was, does the urinary bladder urothelium contain functional V2 receptors? And if so, what are they doing there? Answer, yes. I wouldn't have asked the question if I didn't have the affirmative answer. But in any case, the bladder epithelium does have V1A, V2 receptors, and it also has aquaporins. And we know from her studies that aging is associated with increased V2 receptors in bladder urothelium, suggesting that Desopressin may be effective in the elderly due to the increased target of the V2 receptor. So the question is it really modulating water? Are we really reabsorbing water through the bladder? Probably not much. It's probably doing something else like modulating bladder sensation, maybe bladder capacity, smooth muscle tone. And in fact, in the older animals, it was found that Desopressin tends to cause smooth muscle relaxation. And that is interesting because that could be a potential mechanism of Desopressin completely separate from what we just thought was strictly an action at the level of the collecting tubule. We are now doing studies in this regard, confirmatory studies at downstate, looking at both the murine models and also a unique population of fruit bats, which it turns out have a GU tract much more like humans than mice. Okay, so here's what you really want to know about is how do we manage nocturia? What do I do for these patients when I see them in the office? Well, first we start with the obvious, behavioral management. We find out how much they're drinking. I don't necessarily measure it. We kind of talk to them. When you take a pill, do you fill the glass with water or do you just take a sip? Because typically they think they cannot absorb a pill unless they just drink it down with a whole glass of water. Do they have diabetes? Do they have glycosuria? Do they have heart failure? I mean, you will diagnose congestive heart failure that's missed by the internist by just paying attention to the etiology of their nocturia. You will also identify edema, so you might see left failure, you might see right-sided failure. You might diagnose hypertension and non-dipping, and you certainly might diagnose sleep apnea if you have a patient who's healthy and has nocturnal polyuria, and maybe you get the story that they snore or they have a wide neck. You want to do sleep studies on them. Another interesting finding was something that we did in our cardiology clinics at downstate. Dr. Jason Lazar, being the senior author here, restricted sodium in his patients and asked them about their nocturia. This was not a diary study, didn't even have a questionnaire, but he asked specifically about how many times at night they got up. And the patients who were adherent reduced their nocturia from 2.5 to 1. And I think that's a big deal because there aren't too many drugs that we give that'll give you that type of positive outcome. How about sleep apnea? Well, I can tell you that it causes nocturnal polyuria. Here's the mechanism: increased airway resistance causing hypoxia with airway obstruction during sleep. Hypoxia causes pulmonary artery vasoconstriction, which increases pressure in the heart. The heart thinks that the circulation is too full of stuff, and it secretes a hormone to get rid of the stuff. That's atrial natriuretic peptide, which inhibits arginine vasopressin and increases renal sodium and water excretion. Does it work? Yes, it does work. In these 3 studies, nocturia times 3.8 went to 0.7, and 2.5 went to 0.7. Here's another study before nocturia times 3 went to 0. You're not going to find this too consistently in your clinic, but I have had a number of patients who came up to me in the hallway and say, "Doc, you changed my life," when I treated them, diagnosed their sleep apnea and treated them with a mask. To be sure, many patients with sleep apnea hate the mask and won't use it and would rather have nocturia. But the ones who are really bothered by the nocturia will use the mask to good effect. Lifestyle modifications. This is the old kitchen sink approach. This is the Atlanta group at Emory, headed by Ted Johnson. And preemptive voiding before sleep, decreasing fluid intake, don't drink a lot of booze and caffeine, exercise, particularly in the evening, kind of wring it out at night, lose weight, timing of medications, don't take your diuretics first thing in the morning, take them in the midday when you really need them, and compressive stockings. The problem is they didn't really look at the individual factors. They kind of put it all together and found that there is improvement, not dramatic improvement, unfortunately, by going through these lifestyle modifications. How about us as urologists? How do we do with these patients with overactive bladder and BPH? Because that's how patients, particularly men, tend to be treated. You'll see that consistently all throughout your clinics. So what about the OAB agents? Well, they don't do very well at all. If you see that most of these post hoc analyses have the error bars at the level of 0. And the only one that really didn't was the trospium study. That was a study by Del Rudy. Even that was not an impressive decline in Nocturia. So antimuscarinics don't do a very good job. We know that overall in the original Detrol extended release study that there was no effect on Nocturia, but then because it was a large study, again, about 850 patients, they did find that the patients who had overactive bladder, which was urgency based on a scale that they had validated, particularly the ones that had severe urgency, they seemed to have a statistically significant decline in the Nocturia. So it's probable that the patients who get up at night and have to run to the bathroom will benefit from an HS dose of a short-acting antimuscarinic, or perhaps even mirabegron. The studies, however, do not support that. Here's a study where the placebo was no different than drug, but I want to point out here that the baseline severity in this study was not very severe. So when you start out with Nocturia times 2, good luck getting an outcome that's going to be positive. How about all those meds that we give for the prostate? Well, here's a study with tamsulosin, drug 3.1, placebo 3.1. Drug went to 2, placebo to 2.3. Statistical significance, certainly not clinical significance. So don't give patients Flomax if you're primarily treating monosymptomatic nocturia. Ted Johnson in a VA cooperative study looked at, again, men only 45 to 80 and found that placebo was almost as good as all that terazosin and all that finasteride. So not very good outcome here with the BPH drugs. How about NSAIDs? Well, I mentioned before that prostaglandin inhibits antidiuretic hormone. So prostaglandin inhibitors act as pro-antidiuretics. So they certainly have efficacy in treating nocturia. The problem is they have a lot of side effects and generally speaking are probably not suitable for a routine treatment of nocturia. But they will improve nocturia, and you'll find from your patients, if you talk to them, that when they're taking their NSAIDs, they probably get up less at night, and probably also an effect on the afferent side of bladder sensation. How about posterior nerve, the posterior tibial stimulation and nocturia? Well, if you see a study with Nocturia times 2 at baseline, you're not going to have a positive outcome. At 24 months, that went down to 1.8. In my view, not very good. Manoj Manga, now chair at UCSD, did a review and found that, yeah, it's PTNS is useful, but the studies were all over the board. Sacral neuromodulation, on the other hand, was found to be very helpful. Here's a study by Carl Kreder's group from Iowa. Most of these patients had overactive bladder, and even the young ones had a fair amount of nocturia, and the outcomes here are very impressive. But notice the baseline, much more nocturia. So if you really want to get a positive study, make sure that the patients have a lot of nocturia. And then almost everything you do improves, which means that it might just be regression to the mean in many of these patients. So don't get all proud of yourself for treatment because some of these patients just get better, and it may be just a subtle behavior modification effect. How about Botox? Well, again, here's a group of patients with multiple sclerosis, baseline 2.14. So you can predict what's going to happen. Nothing. But in the patients who had Parkinson's and multiple systems atrophy, their baseline was 5. And this was a study done in Italy. And at 4 weeks, they were at 2. And at 12 weeks, 2. So Botox helps nocturia in Parkinsonians. particularly those with severe baseline nocturia. And that pretty much goes across the board with all these treatments. How about surgery? There's a lot of surgery that's been done, particularly in the old days for nocturia. You got nocturia? Bang, a little electric treatment of the prostate. That's what we used to do because, again, we didn't have much else. The rationale: lower residual urine, increase bladder capacity, reduce frequency, destroy afferents in the prostatic urethra. And this is number 3 is a Marcus Drake, one of the smartest guys I know, statement: relieve the obstruction and negate the mysterious connection between obstruction and intruder overactivity and urgency. And I think that's actually true, that's one of the ways that outlet reduction works. Well, how about radical prostatectomy? At one time, Dr. Herbert Lepore was doing 400 radical prostates a year and had a lot of patients and studied his patients beautifully and found that their lower urinary tract symptoms improved dramatically, except nocturia. But they most likely did not have that much nocturia to begin with. On the other hand, a more contemporary study using robotic prostatectomy, particularly again with a higher baseline nocturia severity of 3, 2/3 of those patients got better. So when you start out with 2, only 14% improved. And when you start out with 3, 67% of them improved. So if you want to do a study on nocturia, no matter what you want to use, make sure the patients have a lot of nocturia. Okay, how about polyuria? Well, we'll go through a bunch of slides pretty quickly here. Polyuria is defined as overproduction of urine globally. Let's say round figures 2.5 liters for 24 hours. They drink too much to keep homeostasis. So they have day and night frequency. Untreated diabetes mellitus, diabetes insipidus, and primary polydipsia, again, dipsogenic and psychogenic. DI is a disorder of water balance, which is central versus nephrogenic. Central DI due to deficient synthesis of antidiuretic hormone, particularly loss of neurosecretory neurons above the level of the posterior pituitary. So the posterior pituitary becomes kind of a storage facility, which then doles out the ADH, but it's not produced in the posterior pituitary. ADH is not produced in the posterior pituitary. So the etiology of central DI, often idiopathic, but can be due to a trauma post-operative for treatment of pituitary tumors, metastatic disease, infiltrative such as sarcoid, Sheehan's postpartum pituitary necrosis, and infections, particularly tuberculous meningitis. Nephrogenic DI, the brain is normal, antidiuretic hormone is around, but the kidneys do not respond. For example, those patients with lithium or patients with CKD, tubular dysfunction. So the diagnostic algorithm is to do a screening test with an overnight water deprivation and just to see if they can concentrate their urine. So I have them go NPO past midnight, come to the clinic, pee as many times as they want, and by about 11 a.m., they have an 11-hour fast, get the urine for osmolality. And if they go up to about 800 milliosm per kilogram, I'm happy, we're done. Normal means they have normal arginine vasopressin and normal renal response. If they don't concentrate, then one has to do a number of tests. For example, you can give them some desmopressin and see if they can concentrate, or you can do your dehydration test. Make sure that they have a high serum sodium at the end of that dehydration, and then measure a copeptin, which is basically going to go right along with antidiuretic hormone. I know you're not going to do many of these tests. Probably the endocrinologist will do it, but I just want to let you know that this is what they're doing. So considerably reduced concentrating capacity indicates renal DI, moderately decreased capacity in psychogenic DI, and central DI, they have normal concentrating capacity with a dose of desmopressin. So in primary polydipsia, they concentrate when you have water deprivation, and only then will I tell the patients to drink less, because I don't want to tell someone who has an obligatory water loss to restrict their intake, because they will become dehydrated or hypernatremic, and that's dangerous. It's also rare, but you know, if you screw something up on a rare disease, you're still going to get sued, even though it's rare. So at least you got to know about this. Dipsogenic versus psychogenic, the patients will tell you. If they have dipsogenic polydipsia, they probably had brain trauma or radiation or some kind of surgery. And the majority of the patients with primary polydipsia just drink too much because they know what everybody knows that's not true, which is that you have to drink water to flush your kidneys. Well, the dumbest kidney is smarter than the smartest doctor. That's what I tell them. So stop drinking so much. Except the stone patients. There you have to really thread the needle between Scylla and Charybdis and get them so that they drink enough to prevent the stones, but not enough to have so much polyuria and nocturnal polyuria. So that's why I think 2 liters is a pretty good target for the stone formers. So you treat their glycosuria, you give them vasopressin analogs in patients with central DI, and that's high dose replacement therapy. That's to be distinguished from the treatment of nocturnal polyuria in patients without central DI, and that's low dose desmopressin, which is typically that intraoral melt, and psychotherapy for compulsive water drinkers. Urologists are the best psychotherapists for these patients. Don't send them to a shrink. Okay, antidiuretic indications. We talked about antidiuretic hormone vasopressin, important for concentration through that interesting mechanism that I had demonstrated previously. It affects urine production and is indicated for central DI, enuresis, and now finally in the United States and worldwide for nocturia. The mechanism of action is that desopressin is a non-peptide which differs from arginine vasopressin by a single amino acid. It retains the antidiuretic properties of vasopressin and lacks the unwanted pressor activity. So desopressin, when binding to those V2 receptors like ADH, increase tubular water permeability and make less urine that's more concentrated. There's an additional mechanism that I did not know about when I take the in-service exam with the residents, and this was a question on the in-service exam, believe it or not, that desmopressin V2 receptors increase urea permeability and increase that ability for the countercurrent multiplier mechanism for urinary concentration. So this is due to activation of the V2 receptor by increasing urea permeability in the terminal portions of the intermedullary collecting duct. I wouldn't tell you this if it weren't, a red star board type of question. So the formulation of the desopressin, the high dose spray used to be given for nocturnal enuresis, but now is only given for central diabetes insipidus. For enuresis, one can give the higher dose tablets to children and not worry about serum sodium. There was an older version of the melt called Minirin, which was marketed particularly in Europe, with higher dose of desopressin melt. And then the United States, the studies used very low dose melt with the finding that women were more sensitive than men. And so the original studies used 25 micrograms in women and 50 micrograms in men. And somehow, because of production details, those numbers morphed into 27.7, half the dose in women as it was in men. There's another very, very low dose desmopressin that was marketed as a drug called Noctiva, but the company went out of business. And while the drug is still FDA approved, it's not being marketed as far as I know at this point. So what's the real data on antidiuretic treatment of patients with nocturnal polyuria? Bottom line, drug minus placebo decreased nocturia by 0.5 per night. Not fantastic, but probably better than some of those other studies where statistical significance was met with a delta of 0.18 or 0.23. I think, therefore, it's important when using desopressin to use it in the right patients. And I think the right patients are the ones who had the nocturnal polyuria syndrome. This is the original data that particularly in men, normal men who do not have nocturnal polyuria increase their output of antidiuretic hormone at night. Women do also, but not as much, because women are much more sensitive to antidiuretic hormone. It's probably due to some X linkage in the genetic encoding of antidiuretic hormone. And so who are these patients? Well, again, that's why I told you in the EpiNP study, up to 10% of that population has the so-called idiopathic nocturnal polyuria, which I think is essentially the nocturnal polyuria syndrome. And I view desmopressin as replacement therapy in such patients. So we did a study on our own patients. When nocturia improves, what actually gets better? So we looked at the patients who simply got better versus the ones who didn't get better, did not split out what treatment got them better. We just wanted to know what they kind of looked like. And the key thing here is that the patients who improved had a nocturia severity of 3.5 compared to the patients who didn't improve, and they were only 2.3. Recognize that as a theme. The patients who improved had a bigger substrate for nocturnal urine production than the ones who didn't improve. And the bladder capacities were essentially similar. So what happened was the ones that got better is that they drank a lot less. Their 24-hour volumes went way down, as opposed to the ones who didn't improve. Their 24-hour volumes went up. And interesting, the capacities, the bladder capacity went down in the patients that improved. Well, how in the world did they improve then? Well, the point is it didn't go down by much. And the other point is we're not very good with all these treatments. These are patients that had all kinds of different medical therapies. We just have very little impact on bladder capacity. So the best we can do at this point in time is influence the volume. Okay, so just to kind of wrap up and get you a little bit more about what we're going to be looking at in the future is the nexus between nocturia and cardiovascular disease. So we talked a little bit about the expected dip in blood pressure in patients, and the ones whose pressure does not dip may have so-called pressure natriuresis, which refers to the kidney's ability to increase the rate of sodium and water excretion, again, independent of the RAS system, as a defense against nocturnal hypertension. So my friend Ronald Victor, we were actually college roommates, and he became the head of research at Cedars-Sinai in Los Angeles. He was doing this study in young Black men aged 35 to 49 in being treated in barber shops in Los Angeles. And it was a fantastic study that was published in the New England Journal of Medicine. They were actually able to significantly impact blood pressure by going into these barbershops and having a clinical pharmacist treat these men. But he also found that their nocturia tended to get better with treatment. So he looked at the relationship between hypertension and nocturia severity and found that the patients who had normotension had the least amount of nocturia. The patients who were treated and controlled had about the same nocturia. The ones who were both untreated and the ones who were treated but uncontrolled, and those were actually the worst, had tremendously increased nocturia. And the reverse was true as well. Nocturia turned out to be very strongly related to prediction of whether the patients have hypertension. So there is a distinct nexus between hypertension and nocturia. And note that these blood pressures were checked in the barbershop during the day. So dipping was not measured in this particular study. But the study did conclude that nocturia may be a symptom of hypertension. You've heard of hypertension as the silent killer. Well, maybe nocturia is actually a symptom of hypertension. So is it really the non-dipping? Well, I'm actually launching a prospective study at the Brooklyn VA to look at non-dipping with home blood pressure monitoring. It's difficult to do the study because it's not, home blood pressure monitoring is not the same as ambulatory blood pressure monitoring, but we're going to try to make some sense of this non-dipping in the real world patients. However, we think that nocturia and mortality could be related through the non-dipping mechanism. And the key is that the right type of antihypertensive therapy will help nocturia. The wrong kind will worsen it and potentially save lives. And lastly, the etiology of nocturia. Well, I've been harping on this waterfall and the nocturnal polyuria, but patients do get better when they don't have nocturnal polyuria. And how do they get better? Well, I can tell you they don't increase their bladder capacity. What happens there is that they diminish their output and they tend to void at volumes closer to their capacity. They tend to drink less and they tend to have a better alignment in nocturnal urine volume with capacity. So the ones who improved were more likely to have greater baseline severity which is a common theme here, lowering nocturnal urine production, even in patients without nocturnal polyuria, may be a rational strategy to treat these patients with nocturia. And this puts it all together. This is the last slide. You have a patient with nocturia, do a history and physical, urinalysis, post-void residual, and a diary. You get your diary analysis, low capacity, look for a urological etiology. They have nocturnal polyuria, look for heart failure, non-dipping blood pressure, treat their CHF and hypertension, treat their glycosuria. They have sleep apnea, do their polysomnography, treat them with CPAP if they have it. They have edema, stockings. They drink too much, have them drink less. If they have global polyuria, don't tell them to drink less until you've done an overnight water deprivation test to screen them. Make sure they can concentrate. If they can concentrate, they have primary polydipsia, they can drink less safely. If they can't concentrate, find out why. Is it central or peripheral DI? If it's central, treat them with Desopressin. If not, well, not much you can do there. And if they have the nocturnal polyuria syndrome, that is nocturnal polyuria without any other ancillary cause, I think Desopressin should be considered as replacement therapy. So that is the end of the talk. And I will stop sharing, and maybe we have a couple minutes for some questions.
Hi, Dr. Weiss, I have a question for you. I have someone who he gets up about 3 or 4 times at night to urinate, but he has no daytime symptoms. And he does have an enlarged prostate, but he empties his bladder. His PVR is very low. And I did a 24-hour bladder diary for a few days. And when he does get up at night to urinate, he urinates maybe 2 ounces at a time. His volumes during the day, he seems to have normal volumes, but he's getting up often, but just urinating small volumes. And I don't think the total volume qualifies for the 33% for nocturnal polyuria. So what are your thoughts on that? When someone gets up a lot at night to urinate, but it's kind of low volumes and it doesn't really kind of match up what happens during the day.
Great. I think first of all, how's his flow and his residual? I mean, that's a guy I want to really know if he has prostatic obstruction, because there's your guy that may actually benefit from outlet reduction if it's really prostatic obstruction. But I think in this case, because of the possibility that monosymptomatic nocturia doesn't always get better with outlet reduction, you want to study them. So that might be a patient who should get, the cysto UDS, or at least, check to see if you really think they're obstructed. Big prostate doesn't always correlate with physiological obstruction. So I think UDS could be very useful here. And if there's high grade obstruction, I have no problem with an outlet reducing procedure. And let's say the patient says, "Oh, forget it, I'm not going to have surgery." Well, then, the best you can do is increase the capacity. So the question is, does he have oliguria? Does his 24-hour output less than 1 liter? And is he drinking very little? It may be that patient just has a low capacity day and night and manages it during the day and becomes, it's bothersome at night. And then the question is, can you increase capacity without prostate surgery, but rather with behavior modification? And what I sometimes do is have these guys void, let's say at a comfortable interval, let's say every hour for a week by the clock. And then the next week, every hour and 15 minutes. And then the following week, every hour and 30 minutes. And until you get them to every 3 hours. And the question is, will that translate into increased capacity at night? That's a practice of mine, but I can't tell you that I've done a study to prove it.
Okay, and I just have one other question. You didn't really mention anything about someone who has just like a primary sleep disorder. Some people, they'll take like Ambien or melatonin or different things like that, and then they'll sleep better. Is there a role for using those kind of medications for nocturia?
Yeah, there's no question that hypnotics improve nocturia. 100% guarantee. It just decreases the brain's tendency to awaken as a result of that stimulus of the full bladder or bladder contraction, as you saw in the crystal study. So it works, but I am loath to give patients hypnotics because they're addictive. So I just stay away from all of those kinds of workaround drugs. But yes, they definitely will improve nocturia. I just hate the drugs.
Thank you.
Yeah, Harris Foss here. Great. A couple of questions. One is one voiding diary enough? In other words, how much do they vary at times? And the second question is, what about combination therapy? We certainly use combination therapy with OAB, i.e. anticholinergic beta-3 agonists with BPH LUTs. Any thoughts vis-a-vis the combination? Particularly, I was thinking in particular anticholinergic DDABP, Desopressin.
100%. So I would say that one diary is better than no diaries. If you're talking to the folks who run the International Continence Society, they would say that one diary is absolutely not enough. You have to do at least 3, ideally 7. The bottom line here is I tell patients to do a couple, maybe 3 if they're diary doers. Some patients will love doing diaries. They'll come in the office with 7 daily diaries. And then you got somebody that gives you a piece of paper that just chicken scratch and there's coffee and urine on it, and you're lucky to get maybe a nocturnal only diary. So you get what you can get. I'll take one if that's all I can get, but clearly there is a differential. They do not have the same outputs every day, which is why it's ideal to get a variety of diaries. Regarding combination therapy, no question about it. When you look at the studies, the so-called kitchen sink philosophy, combination is what we do, and we kind of have to do it because the point is that nocturia is so multifactorial that if you just treat one pathophysiological variable, the chances are that there's another variable that's just as important. So I really do think that combination therapy is the mainstay, and we rarely have that monotherapy silver bullet, which we will have more likely in the younger patients where multifactorial etiologies of nocturia is not the case.
All right, well, I have one more question. At least I recall, some people have talked about, I don't know, maybe nobody, but about, in patients who are taking diuretics, they always say, well, I take it in the morning, I got to, urinate multiple times. They obviously become somewhat dehydrated. What about what are your thoughts about having them take that diuretic in the evening so that they're effectively dehydrated before they go to bed, hence lower nocturnal urine volume?
Fantastic question and very important question. Most patients take their diuretics first thing in the morning, which is when they need it the least because they've been up all night peeing and they're pruned in the morning. So I tell them if they're taking Lasix, I'll tell them to start at about 3-4 o'clock. Now, if they're kind of active, let's say retirees, they may not want to take a diuretic in the midday because they don't want to have a bathroom nearby. Taking a diuretic late at night is counterproductive because they're going to be up all night peeing as a result of the pharmacokinetics of the drugs. Now, getting into the other diuretics, like the non-loop diuretics, such as the thiazides, you've got thiazide, hydrochlorothiazide, which is a short-acting thiazide, and you've got the long-acting ones that are indapamide and chlorthalidone. Interesting thing about the thiazide diuretics is that they're not diuretics in the chronic phase. They are smooth muscle relaxant. They relax vascular tone. And so they don't work the same way, but we think, and this was a contribution of Dr. Victor before he passed away in 2018, he thought that the long-acting thiazide-like diuretics like indapamide and chlorthalidone are more likely to stay around at night and address that potential non-dipping factor of blood pressure. So we don't actually have sufficient studies to prove that. But I think the main question you had was, if I see a patient who takes Lasix, can I tell them to just take it in the midday as opposed to first thing? And the answer is yes. And it's a great thing because you don't own the Lasix. Still, the primary care doc has to worry about all the problems like the potassium. So you're just telling them to take it at a different time. And I guarantee you, there isn't an internist in the world who's going to argue with that. but it is an important thing to know what meds they're taking and what time they take them. And so your question is very well taken.
All right. So I think you talked about treatments for overactive bladder, PTNS, sacral neuromodulation, et cetera. Maybe I missed it, but because I'm driving. But what about Botox and Nocturia? I mean, because that directly impacts bladder capacity, right?
Definitely.
Well, in theory.
Yeah, absolutely. I think Botox is great. If you've got someone with low capacity and they're not doing well with anticholinergics, I think the studies are there. So I think that you have a basis in terms of the literature to support it. And I would definitely say if you're enthusiastic about Botox generally, that it can be very useful in patients with nocturia that doesn't respond to the standard behavioral therapies.
Dr. Weiss, this is Isaac Kim again. Really enjoyed your talk. I'm kind of like running between seeing patients right now. But what's the latest science right now, trying to improve or increase bladder capacity in these patients?
In which patients? Just nocturia patients generally?
Yes, that's correct.
Oh,
what's the latest science on this right now?
That's the $64,000 question, is how do you increase bladder capacity? And if you look at the studies, like if you look at the more recent, let's say Mirabegron studies, and you look at the increase in voided volume per void compared to placebo, it's something like 8 cc's. So do the math. If you've got patients getting up 4 times at night, and you're going to give them, even if you give them the placebo effect, you're going to give them about 15 cc's more capacity in the reservoir at night than without the drug. And let's say they're getting up 4 or 5 times. That means you're increasing their capacity by 60 to 75 cc's. And that is just not going to do it. It is not a sufficient way to increase capacity. So as far as I'm concerned, there is no really reliable treatment for low bladder capacity at all. We'd love to think that the men who have high-grade prostatic obstruction who get treated will increase their capacity. I think that is most likely true. But we also know that generally speaking, bladder outlet obstruction relief is not a very good way to treat nocturia. So if you're going to use outlet obstruction, diminished urethral resistance to treat nocturia, you have to really study these patients carefully and make sure that they don't also have nocturnal polyuria, sleep apnea, or other things that are going to compete with your treatment and obscure the benefit. I don't know that completely answered the question, but the bottom line is bladder capacity is remaining one of the big untreated substrates for nocturia.
Got it. Thank you.
Thank you, Dr. Kim. Well, thanks everybody for your time and attention. And anything comes up clinically, just give me a yell. I'd love to talk about any individual patients with any of you.
Dr. Weiss, again, thank you very much. And I want to thank you on behalf of the department. Really enjoyed your talk today. Have a great weekend.
Thank you. That was a great talk. Really appreciate it.
Thank you, Dr. Sprinkle. Good to see you. So long, everybody.
Thank you, Dr. Weiss.
Great day.
Dr.
Talk to you
Weiss.
soon. Pleasure. Bye now.